I'm Mwajuma Masaigana. I work with the People's Health Movement East Africa in Tanzania. The general health situation in Tanzania is that Tanzania being a poor country, so its people are also, most of them are poor, and those poor people, most of them also live in the rural and rural-urban areas. In that case, it's almost impossible for them to access health facilities and drugs.
This is the supervision list, which makes sure the officials and coordinators of different health programs in the districts visit the health facilities. But despite of this mix we are having, we meet one individual at the health facility. So it's like all the different health programs pumping the same person with all this bulk of information. Can be confusing sometimes. You might be receiving this delegation from the higher level visiting your office. And right maybe after 30, 40 minutes you receive another delegation from this another important vertical program, and after 1 hour or two you get a phone call, we have this emergency visit to your office on this and that. It's another vertical program.
We have to address the issue of quality in staff, quality in equipment, quality in services. We have to address the issue of access to drinking water, access to proper housing, and access to healthcare services.
From our studies, we have seen that 30% of the poorest do not receive effective treatment. It's not a question of having the drugs only in public facility, but also to make sure that those who actually need most, which are mainly the poorest, do also access. Now we have a lot of public-private partnerships which are around, but we don't know how much the people on the ground are actually benefiting. A good analogy is the question of a bullet and the gun. If you have a bullet, these are disease, like drugs, vaccines, but in order to use the bullet, you need to have a gun, and this is the health systems. And we see now more and more people are more interested on bullets, and less are interested, have interest on the system.